So we've spent all quarter really going through different modalities and precautions and contraindications and everything. And so now we're sort of going back to the beginning of the book and trying to tie it all together. So a lot of these agents can be used or various agents can be used for the same effect. We have to decide how we're going to use them, where we're going to use them, what effects they're going to have on the patient. So how do we do that, right? How do we decide what is the most useful modality for that patient, and how do we integrate that into the rest of our physical therapy interventions? So we want to prioritize our goals and the effects of treatment. So this is from the book in chapter 1, and it's sort of a little chart rating things on a spectrum from the highest or first priority to the lowest and last priority. Certainly, if we can have an effect on the primary underlying problem, that's best case scenario, right? And we want to prioritize that as our treatment goal. We don't always have an effect on the primary underlying problem. As we talked about extensively in pathophysiology class, a lot of times we have little effect on the primary problem. And we are treating more secondary issues, either resulting from the primary problem or trying to prevent a deterioration or side effects from the primary underlying problem. The other higher priority thing is a problem that's most likely to respond to treatment. So frequently we get people referred to PT because they have an issue that is likely to respond to the type of treatments that we are going to do for them. So improving range of motion, addressing pain, tissues with people with motion restriction in tissues with a lot of collagen, sure, we can affect that, collagen extensibility. Muscle tone problems, different disabilities and functional mobility issues. Those are all things that can respond to physical therapy. So it might not be the primary underlying problem, but it's things that we can address. So those are high priority things. Sometimes we have treatments that are going to address more than one problem simultaneously. So that's great. That's kind of a good high priority. Sometimes we are treating symptoms only. So we're not going to make a big change in the underlying problem, but we can have an effect on that person with symptomatic treatment. And of course, that's kind of the lowest priority, strictly symptomatic treatment. So when we're selecting physical agents, we want to consider our goals and effects of treatment. What are our goals and what effects do these individual physical agents have on that? Contraindications and precautions, certainly. Is there evidence for the use of physical agent in this particular disorder or setting? And then the cost, convenience, and availability of the treatment. So with the goals of treatment, just like I was saying, tissue healing, pain reduction, increased range of motion, decreased muscle tone, muscle strengthening, decreased muscle spasm. A lot of times when we address those things, at the same time we're also addressing functional mobility. And when we get these things under control, it has a positive effect on functional mobility. So those are the kind of treatment goals that we see in physical therapy. Contraindications and precautions. Is the modality safe for this patient in this setting? So one thing I did when I was in school, when I was taking a modalities class, I'm a big picture person, so I like to kind of have it all in one big chart or something. So I made one big spreadsheet with all the different contraindications and precautions and all the different modalities and how they interact. The interesting thing is you do see patterns. There are some things that we've seen come up over and over again throughout this quarter in every different chapter. Pregnancy. It's generally a contraindication or a precaution for any kind of physical agent if the physical agent or its physiological effects can reach the growing baby. These we don't want to do things that influence fetal development. A lot of times the influences on fetal development are not known, or because there might be some subtle effect that can influence it that we don't know about. So you don't want to take any chances with that. So a lot of times pregnancy is a contraindication for a lot of physical modalities. So if we said, is the modality safe for this patient in this setting? If the patient is pregnant, the answer to that is probably no. Malignancy is a contraindication or a precaution for most of the physical agents that we talked about this quarter as well. A lot of the physical agents that we talk about accelerate tissue growth, accelerate vascular permeability, accelerate the proliferation of cells. That is not what we want to have happen with malignant tissues because they're already accelerated. And we don't want to do anything that's going to break up those cancer cells and cause them to spread throughout the body and give them a chance to metastasize. So there might be malignant tissue in an area that hasn't been detected yet. So doing a modality, that's a precaution in that area. We don't want to do anything that's going to affect, accelerate healing or affect cell permeability or affect vascularization. Because remember in pathology class we talked about the carcinogenesis process and how you get that hypervascularization. So we don't want anything that's affecting that. If people have pacemakers or spinal cord stimulators or deep brain stimulators, those have a lot of times the physical modality that we are applying has an effect on the implanted device. There's so many different implants now. There are insulin pumps, there are pain pumps, there are intrathecal baclofen pumps. So a lot of different things that we don't want to mess up for that patient. They have that implant done because it's something that they really need. And we don't want to use any kind of physical modality that's going to mess that up for them. Impaired sensation and mentation are always contraindications or precautions for physical agents because it's difficult for the patient to report how the intervention feels. So if someone has impaired sensation, most of the heating or cooling modalities, they're not going to be able to tell you if it's too hot or too cold. Same thing with impaired mentation. They might not be able to tell you, they might not be able to communicate, and so we don't want the application to be unsafe. So if we ask in that case, is the modality safe for this patient in this setting, the answer would probably be no for impaired sensation and mentation. So that is something really, those, whatever modality you're using, those four things really are something to really consider. So not to say that you couldn't use physical agents with impaired sensation and mentation, but you want to be very, very cautious about it. So the other things is we want to make sure that we are not making anything worse. We definitely want to improve things. We want to do no harm. We want to help the patient. We don't want to harm them. And so we want to really be careful about any physical modalities that we are trying to apply to the patient, because we're really trying to help them. We're not trying to hurt them. So with scientific merit, does the research support the treatment? Is there evidence available to suggest that this is an effective treatment for the stated goals? So it really has only been in the last 15 to 20 years that this has been coming to the forefront. Evidence-based treatment, research-based treatment. We want to know that there is research to support that we are doing something effective. We don't want to waste people's time. We don't want to waste people's money. A lot of times in the past, things were done more clinically with clinical observations. They'd say, well, I've used this in the past before and it's always worked for my patients, so I'm going to keep using it. But now we like to, the general medical community likes to approach things from an evidence-based standpoint. And so I think in your first quarter in PTA 101, you had an evidence-based research project. This is going to keep coming up. And in this class, we had an evidence-based research project. Next quarter, in our winter quarter project, I'm going to have you do some research about treatments that people have received for neurological treatments and whether this is an effective treatment. So this is a continuing theme, and I really would like to see that continue into your clinical practice after you graduate from the program and pass your board exams and become PTAs. Sometimes I will look up a research article. I will have a specific treatment because I'm always looking stuff up for you guys and trying to keep my teaching fresh. A lot of times I find out about new research that's out there, and so I will present it to PTs that I'm working with, and I'll say, hey, I learned about this new technique. Here's a research article that supports that it's effective, and I think we should do it with this person. So that's a pretty good argument. And sometimes, too, you get in the role of having to discuss this with a doctor, like, yeah, this really is an effective treatment, and here's some research to indicate that this is true. So it's really a good thing to know about the treatments you're applying to people. Cost, convenience, and availability. So I talked a little about this in the electromagnetic radiation lecture. There are some treatments, such as cold laser treatment, that are not covered by insurance. A lot of patients, they do not want to do something that they're going to pay for out of pocket or pay excessively for out of pocket. So the other issues with this in terms of convenience and availability, who's going to apply the modality? Is it something that we do? Is it something that we teach the patient and they do on their own? Can they use it at home? Or a caregiver can help them with it? How much time does it take? Is this something that they're going to be spending a lot of time doing at home, or is it something that you're just going to do in a short amount of time? Is it covered by their insurance? So I talked about it in the electrical stim lectures, how TENS used to be something that was only available by prescription. It was quite expensive. And now it's a lot more cost effective. You can just get it anywhere. So convenience is right up there. High availability. The patient can use it at home. And whether or not it's covered by the insurance, it's affordable, and so it's definitely become a more accessible treatment. So the sequencing of modalities within the PT treatment session, how are you going to sequence your session and why? What other interventions are you going to be using besides physical modalities? So a lot of times we will use physical modalities to warm up before we do therapeutic exercise, to increase range of motion or tissue extensibility before we do therapeutic exercise, so the exercise can be more effective. How are we fitting that in? Why are we doing it in a certain sequence? How are we doing it? What effects are we trying to have? What's the most beneficial thing for the patient? So this is in chapter 2 of the book. I thought it was pretty interesting. It's the International Classification of Functioning, Disability, and Health. So it's really, you see, there are a lot of factors affecting people's activity levels and what they can do. So their body functions and structure can affect it, and that's where the physical agents have their effect. Environmental factors, contextual factors, personal factors, participation, health condition, their disorder or their disease, all of these things are interrelated and affecting. So if we can affect that spectrum at any level, we can help improve somebody's activity. We can help improve their mobility. We can help improve their quality of life. And it's a huge, big deal. I mean, honestly, for me, that is why I am in this field. I love helping people improve their lives, even if I do it on a very small level. That is my reason for being there. I want to help people get better. I want to help people do what they want to do and live the life they want to live. So a lot of times modalities are passive treatments. We are doing something to a patient. They are not doing something in response to it. So frequently we start off when they're in a more acute stage. We start off with modalities, and we have to decide, when are we going to taper off modalities in favor of more functional activities? When or if we're going to taper off the modalities. I have certainly worked in clinics where it was the general practice to do modalities from the first day the person walked in the door till the day they walked out of the door. And I've worked in other places, in the place where I currently work, where the idea is you start someone off with modalities, and then as they improve, you taper off the modalities and you work more into active treatment. So earlier in the year, I was working with a guy who was in a rear-ending car accident. He had whiplash. He was very active, had a very active job. He was in a lot of pain, and he came in right after the accident. He went to his doctor, and the day after he came into PT. So he came in a very acute stage, and we started off with mostly modalities. We're doing ultrasound, we're doing soft tissue mobilization, and then as he got better, as he improved, we were starting to add in more stabilization exercises, more. And then as he got better, we were tapering off. We weren't using ultrasound anymore. We weren't using any electrical stim. Very little soft tissue mobilization. And we were mostly doing strengthening and return to function type activities. So with this guy, since he was healthy and active and everything, and he never stopped his activities, but getting back to doing them functionally without a lot of pain, we didn't have to continue with his modalities. We tapered off them. Some modalities might be part of a home program. If you have someone with chronic pain, it might be that you're going to recommend that they get a TENS unit for home, and they're going to use it on a regular basis. Ice and heat, those are really good modalities to recommend as being part of the home program. You have to decide how you're going to educate the patient in the home use of the modality. And we did a couple of these for heat and cold applications this quarter. How are you going to tell your patient the proper and safe way to do these? So ideally, even if someone starts at a very acute stage and you're doing a lot of passive treatments, ideally as they get better, you are going to be moving into more active treatments. So you are not going to it's not going to be passive for the entire course of their treatment. A lot of times, even if you have someone with a chronic neurological issue, you are not spending your whole time doing passive treatments. The more they can use their affected limbs, the better results they're going to get. And so integrating modalities is a great way to help affect tissue healing and affect pain and affect the things we want to affect, but it is not the only thing that we're going to be doing, and we are going to be progressing to a more active treatment effect.